Hello, I do apologise for the audio issues we've had. I'm recording this on my own after the event, so I do apologise. However, I hope the wait will be worth it. This is a presentation about the biomechanics or the pathomechanics of plantar forefoot blisters. So let's jump in and make a start. We're going to look at the forces involved. We are going to understand that there's a biphasic shear event under the ball of the foot as opposed to under the heel, which is just a single shear event. We're dealing with an intraepidermal tear when we're dealing with blisters, and we're going to have a close look at the opportunities to reduce shear deformation under the plantar forefoot. In other words, how to prevent blisters. And we've got some really good Q&A, so we'll get into that at the end if I've got time. So is it really important to understand the pathomechanics of friction blisters? Well, I think it's fair to say with any pathology, to understand the cause is actually absolutely essential. We can't expect to be able to choose the best preventions or treatments if we don't really understand the cause. So cause must inform prevention. If you are under any illusion that blisters aren't that common, think again. They're the most common injury in sport. We have the research in running, hiking and netball at least. The others haven't been researched, but just experience tells us that blisters are quite common, and unfortunately we don't get many of our patients ask about them. So there are various reasons for that, and I hope to help you become more helpful in helping your patients with their blister issues. So we're going to have a look at a video that Doug Ritchie and I have been working on for several months that really explains this in really good detail. So I'm going to play that video now. It goes for about 13 minutes and then we'll get into the nitty-gritty of prevention. So bear with me.
People experience many benefits from participation in sport and recreational activities. At the same time, there are associated risks of injury. Specifically, friction blisters on the feet are among the most common injuries sustained in running, walking, and many sports. Unfortunately, there are several misconceptions about what causes friction blisters. The most significant of these is that they are caused by objects rubbing on the skin, presumably by the sock or shoe. To understand how friction blisters occur, we need to look at how the foot and shoe move while on the ground. We need to appreciate all the material layers involved, and we have to look at forces. There are vertical forces and horizontal forces. Vertical forces from impact and gravity cause compression. Horizontal forces from momentum, from muscles pulling on bones, and from friction create shear forces which make materials bend and stretch. Vertical and horizontal forces exert their effects between pairs of materials at their interface and within materials that deform. For example, friction between your shoe and the ground prevents your shoe from slipping out from underneath you. Consider a runner on the road or an athletic track. The materials of the sole of their shoe and the running surface itself, plus the compression underfoot, all help provide traction so every running stride is maximally efficient. There are similar forces that resist sliding of your foot in the shoe between your skin, sock, and the shoe lining material. In a way, this is by design. Footwear manufacturers construct outsoles that promote traction rather than slipping. Sock manufacturers use materials that are much less grippy so you can pull the sock onto your foot easily and slip your foot into your shoe easily, yet still help provide some level of traction for your foot in the shoe. Plus, the moisture from perspiration further increases traction. The opposite of these traction scenarios would be running on a slippery floor or running with Vaseline on your feet. There's a lack of traction, which will be particularly noticeable at heel strike and push-off. These are all examples of how two materials interact with one another at their interface to either slide or resist sliding. Vertical and horizontal forces also act within materials. These materials bend, stretch, and deform, which is described as shear deformation. At heel strike, your body's forward momentum is countered by friction, which keeps your shoe held stationary to the ground. The result is not only compression of the midsole, but also shear deformation within it. The same thing happens within the soft tissues of your foot at heel strike. There is forward momentum of your calcaneus, but this momentum is resisted at every interface external to the skin surface by the force of friction, giving your foot traction within the shoe. The result is shear deformation, stretching and deforming of the soft tissues sandwiched between skin surface and bone. It is worth noting at this point something very important about friction. Friction force is the mechanical property which prevents sliding. Friction force provides traction for efficient gait. Friction is not rubbing. Friction force actually prevents rubbing or sliding of the shoe across the ground, of your sock against the lining material of your shoe, of the sock against your skin, and at any other material interface that might exist within your shoe. Interfaces slide when there is low friction force and stick together when there is high friction force. Friction force is determined by two things: the compressive force pressing them together and the surface properties of each material. Each pair of materials has its own tendency to either grip together or slide over one another. Pressure increases friction force and prevents sliding across material interfaces. There is generally high pressure under the foot, resulting in high friction force. Material selection in the manufacture of footwear and socks, plus perspiration, tend to prevent sliding. This all contributes to high friction force at every material interface external to the skin. All in all, high friction force dictates a tendency for stationary contact between all the interfaces from skin surface to ground. So, high friction force produces better traction. Traction helps resist forward slippage of the heel during heel strike and resist backward slippage during push-off. Friction provides traction which is needed to resist momentum of the bones pushing against the skin at heel strike and muscle action pulling on tendons which move bones against the skin during heel rise and push-off. Moving bones in the presence of high friction force dictate a significant shear event within the soft tissues of the foot with every step, which is all part of normal function. The foot is designed to endure this shear deformation. However, as we will soon see, there are limits to what the foot can tolerate before skin injury occurs. Now let's focus on how the soft tissue components of the foot compress and deform during a single stride from heel strike to toe off. We're going to assume that there is good traction of the foot in the shoe, so there is little to no sliding between the skin and the sock, or the sock and the interior shoe lining, or of the shoe on the ground. We recognize that shear deformation does occur within the components of the shoe itself. However, we're going to focus solely on the shear deformation that occurs within the soft tissues of the foot, with a particular focus on the plantar surface and the posterior heel. At heel strike, the foot approaches the ground at an angle which is not purely vertical or horizontal, much like an aeroplane landing on a runway. The vertical direction of touchdown causes compression of all the shoe and foot materials under the heel bone, and to a lesser extent at the back of the heel. The horizontal direction of touchdown creates shear forces in these compressed soft tissues. Essentially, the calcaneus is moving down and forward, but the skin surface doesn't follow because friction is holding these in-shoe interfaces stationary. The soft tissues sandwiched between skin and bone bend and stretch as a result. They undergo shear deformation. At foot flat, pressure is exerted to the metatarsal heads as it reduces under the calcaneus. The primary force acting on the foot comes from gravity, and forward momentum continues. Shear deformation reduces at the heel and increases under the forefoot. During mid-stance, as the tibia moves forward over the foot, tensile force builds in the Achilles tendon, pressure increases under the forefoot, and the arch flattens a little. Essentially, the metatarsal heads push down and move forward. Friction force is increasing under the ball of the foot, holding the skin surface and sock stationary within the shoe as the metatarsal heads move forward relative to the skin. This creates increasing shear deformation in the soft tissues under the forefoot. At heel rise, pressure is removed from the plantar calcaneus as elastic recoil of the Achilles and plantar ligaments lift the calcaneus and increase pressure and friction force under the forefoot and toes. Contraction of the flexor muscles of the leg pull the phalanges and the metatarsals down and backwards to generate forward propulsion. This heralds a reversal in the direction of shear deformation within the soft tissues under the forefoot and toes. There's also a less significant shear event at the posterior heel in the opposite direction to that experienced at heel strike, as now the calcaneus is being pulled upwards. With increasing heel lift during the final moments of stance, the metatarsophalangeal joints are further dorsiflexed on the fixed phalanges as the metatarsals are being pulled further downwards and backwards. The center of mass moves ahead of the foot while the bones of the forefoot are being pushed backwards relative to the skin surface, creating a significant shear event in these tissues. Friction force is high under the forefoot and toes to enable efficient toe-off. As the foot leaves the ground and enters into the swing phase of gait, plantar shear is all but eliminated until the next touchdown. Let's zoom in now and look at the layers of soft tissue which are sandwiched between skin and bone. The bone is at the bottom of the screen now and the skin above, so you could imagine this image as viewing the dorsal surface of a clawed toe. Remember, it doesn't matter which part of the foot this is depicting, it is the bone structure that initiates movement. You could envisage turning this image upside down and it would then depict the relationship of a metatarsal head pressing down onto the ground, or turn it to the side to depict the posterior calcaneus. Now let's zoom in further and look at the very outer layer of skin where blisters occur, the epidermis. The base of the epidermis is being pulled back and forth as movement is transmitted from the moving bone, which is now off screen. This movement is able to be transmitted from deep to superficial because every layer of soft tissue is structurally connected to the layer above and below. You'll also notice that the shoe, sock, and very surface of the skin is not moving. So the bone is moving in one direction and the skin, sock, and shoe interfaces are being held stationary. This out-of-sync movement creates shear deformation within the layers of the epidermis. The zone of least resistance to repetitive shear deformation is the lower section of the stratum spinosum. This is where the blister injury occurs. Repeated shear episodes lead to breakdown of the intercellular connections and desmosomes which hold the cells of the stratum spinosum together, and the cells themselves are damaged. The remaining layers of the epidermis remain intact during the formation of the friction blister, forming the blister roof. As the desmosomes fail and skin cells die, small pockets or voids are created which fill with fluid. You won't see the typical blister bubble on the surface of the skin immediately, but the damage is done and a blister is on its way, even if you cease the blister-causing activity. As more and more pockets of fluid coalesce, the volume of fluid at the injured site causes the outer skin to bubble up. It can take up to 2 hours for a blister to become fully filled with fluid after the initial tear has occurred. The breakdown of cells of the stratum spinosum is the result of bone movement, not objects rubbing on the skin surface. It is the lack of synchronous movement of all the layers above the bone which cause structural failure within the stratum spinosum. The risk of blister injury is dependent on both the magnitude and the frequency of this shear deformation experienced by the soft tissue. With high friction and no sliding at an interface external to the skin, a larger magnitude of shear deformation occurs in the soft tissues, increasing the likelihood of mechanical failure within the stratum spinosum. The take-home message is this: the motion that creates the friction blister occurs from inside the foot, not on the outside. Nothing need rub against the skin surface. On the contrary, when the skin is held stationary, the magnitude of shear deformation is larger, bringing with it greater potential for structural failure within the epidermis. If the top layer of the epidermis is allowed to slide freely or in sync with the underlying bone, shear distortion will be minimized within the soft tissues sandwiched between skin and bone. Reduce friction force at one of these interfaces and the skin will be able to slip and move in sync with the bone at an earlier moment, reducing the magnitude of each shear deformation. This is how many blister prevention strategies work. They encourage a little bit of slippage at an interface. This will be the topic of an upcoming video, how blister preventions actually work. If you'd like to be notified of when this new video is posted, please feel free to subscribe to this channel. Thanks for watching.
Okay, so the 4 things I just want to hammer home. Friction is not rubbing. Friction is the force that resists rubbing. So friction here is the red arrow. It's not actually indicating movement, it's just the resistance to movement. Just like how when you press against a wall, the wall doesn't necessarily fall over. It just resists that push. So that's what friction force is doing here. It's resisting the movement of the bone. Shear is the stretching or the deformation. Now the colour of the arrows are the same here. So the bone movement is the blue one. So at the top of this, let's say viscoelastic box, we've got a movement force trying to move that box to the left. Friction at the base of the box is resisting that motion. And so everything in between has to stretch and distort to allow for that mismatch. So just imagine the skin cells stretching back and forth and all their connectors kind of fatiguing after a while because there's just been too many episodes of shear. Shear is the stretching and deformation. And shear peaks in a state of static friction. So there's 2 ways to measure friction. The static coefficient of friction and the kinetic or the dynamic coefficient of friction. The highest is always the static coefficient of friction. So the higher the friction at the bottom of this box, the longer it stays stationary. Now, all other things being equal, i.e. the bone has to move a set amount, the higher the friction, the more the mismatch, the larger the shear deformation. So one way we can reduce the shear that occurs in this viscoelastic box is to, and assuming that the bone has to move to a certain amount, is we can release the bottom of the box from the hold of friction by reducing friction levels. And if we can do that, then as the top of the box moves to the left, the bottom of the box will be able to slide along with it in the same direction to the left at an earlier moment with each step or with each shear deformation. And that's how we can reduce the magnitude of shear. So it's not about rubbing. Blister prevention is not about stopping rubbing. Rubbing's not what we're trying to avoid. We're trying to minimize shear, and that often means encouraging rubbing. Just let that sink in for a moment. Reducing friction means encouraging rubbing. And finally, it is a biphasic shear event under the forefoot. So at mid-stance, as the forefoot takes load, the metatarsal head moves forward, and therefore the shear event is, or the shear is directed anteriorly. However, after heel lift and as the foot progresses through to toe off, there's a reversal of the direction of that shear deformation. It occurs posteriorly because now the metatarsal head is pushing down and back. Now, if we compare that to the plantar heel, underneath the heel there's only one shear event at heel strike. So could that be why we are more likely to see blisters, calluses and ulcers under the plantar forefoot? Very likely. So friction is not rubbing. Friction is the force that resists rubbing. Shear is the stretching and deformation. Shear peaks in a state of static friction, and it is a biphasic shear event that we're dealing with at the ball of the foot. So let's get into preventing blisters now. There's 4 ways that we can reduce the magnitude of shear deformation. We can reduce bone movement, we can reduce friction force, we can absorb shear, and we can spread shear. Now, all of those things are depicted here in the orange. So we're going to ignore the fact that if you don't walk as far or play as long, then you're going to reduce blisters, because that's not particularly helpful. We're also going to ignore, just briefly, the fact that we can increase the skin's resilience to shear deformation by becoming more accustomed to the footwear and the activity. That will work to a certain degree. But we're going to really concentrate on how we can reduce the magnitude of these shear distortions. So those 4 things that I mentioned, we can reduce bone movement, we can reduce friction force, and there's 2 ways to do that: reduce pressure and the coefficient of friction. We can use materials to absorb shear, and we can spread shear load. So firstly, bone movement. Why might the bones move too much? Or in what circumstances might we be able to have some impact on bone movement? Well, think about ligamentous laxity. So there's larger bony excursions. And think about flexible or compliant flat foot. So people that have a high arch on non-weight bearing, but a flatter arch on weight bearing. So compliant plantar flex first ray, compliant forefoot valgus, and a compliant anterior cavus or forefoot equinus. All of these issues, you can imagine that the forefoot is, the arch is high, the forefoot receives load, and the metatarsal heads roll forward over the stationary skin. So treatment, we can use orthoses with good arch contouring. That we might get that through a first ray wipe. We would be looking to invert the rear foot, so trying to prevent excessive pronation at the rear foot, so we could use a rear foot post and a medial heel skive. We could use a forefoot extension 2 to 5, so that is basically padding under the 2nd to 5th metatarsal. When it's the first metatarsal head, we're trying to save from blisters with a forefoot valgus or a plantar flex first ray. A heel height differential on the shoe and or a heel lift can help. It stimulates the, it assists the windlass mechanism and sort of prevents excessive arch flattening. And we can try and increase ankle joint dorsiflexion if that is limited through stretches and mobilizations. Secondly, we can reduce friction force. Now remember, there's 2 ways we can do this, because friction force equals the normal force, i.e. pressure, times the coefficient of friction. So if we concentrate on pressure for the moment, why might we have too much pressure under the ball of the foot? Well, we might have all of the same issues, but they're a rigid or a stiff forefoot valgus, plantar flex first ray, anterior cavus or forefoot equinus. And we might have reduced ankle joint dorsiflexion. So there's a earlier loading of the forefoot, so there's a higher magnitude and longer duration of load under the forefoot. How might we treat that? To reduce pressure, I'd like to think that we all are pretty good at this, so we could use orthoses, a couple of things in terms of orthotic prescription variables. We could look for a forefoot extension 2 to 5 again, a met dome, heel lift and a heel height differential on the shoe. Some people think that if you lift up the heel, you're putting more weight on the ball of the foot. Well, actually, you are keeping the heel loaded longer by using a heel lift and a heel height differential, particularly if there is limited ankle joint dorsiflexion. So that can be very helpful to lift up the heel a little bit. Of course, if the calf is tight, we would try and get more ankle joint dorsiflexion through stretches or mobs. And cushioning materials reduce pressure, so Spenco, Poron, that kind of thing. The second way to reduce friction force is to think about the coefficient of friction. So this is just the nature of the interaction of 2 materials against one another. Why do we have a high coefficient of friction in the shoe under the forefoot? Well, our feet sweat, obviously, and also the material properties of the sock and the shoe lining. So how can we manage that? Well, we can use Engo patches. So what we're doing here is we're getting slippage sooner than if we didn't have it, and that slippage is happening between the shoe surface and the sock. The sock is able to slip and slide over it. We can use armor skin socks. So armor skin are a double sock mechanism. You use the armor skin sock as the inner sock, and you use any athletic sock on the outer. And what happens here is the outside of the armor skin sock is quite slippery. So it means that any slippage is going to happen between the two sock layers. We can use lubricants. Lubricants encourage slipping between the skin and the sock. That's fine as long as there's enough lubricant there and it's going to last long enough. Frequent reapplication is required because it disperses into the sock or into the shoe material. And of course, all moisture management prevention strategies are aiming for a lower coefficient of friction by keeping it dry. We can use materials that absorb shear. So these include cushioning materials like Spenco, that could be an insole or an orthotic cover, or even Poron and other similar materials. The research indicates that Spenco works better than Poron. We can use thick, densely padded socks. Conceivably, the sock, if it's thick and cushiony, undergoes a bit of shear. So the more shear that can happen external to the skin or external to the foot, the less it happens inside the foot. And we can use gel products. Gel products are maybe not so relevant to under the forefoot, but definitely under the toes. And all around the toes, really. Gel, Silipos gel, for example. And finally, we can spread shear load. This is how taping works. We tape an area, or we put moleskin on an area that is bigger than the blister. What that does is, instead of shear peaking at a very discrete location, we're kind of spreading that shear load over a larger surface area. So that's how we can reduce plantar shear, plantar forefoot shear, reduce bone movement, spread shear load, absorb shear with cushioning materials, and reduce friction force with either pressure reduction or coefficient of friction reduction. Okay, let's get into the question and answers. Question from last month is, can you demonstrate blister taping technique on an actual foot? I'm not going to do that, and the reason is it's not about technique. So if you're not getting good outcomes because of taping, or if your patient's not getting good outcomes with their taping technique, it's probably not the technique, unless it's like just really poorly executed and creases and folds and all that kind of stuff, which is unlikely. It's not about the technique. I want you to think outside of taping. If you're really honed in on taping, you're probably still in the camp of friction is rubbing. And so you're trying to stop anything from rubbing the skin by sticking something to the skin. Well, if you stick something to your skin, you don't negate shear. It does reduce it a little bit, but not a lot, put it that way. So I had a telehealth with a Victorian netballer last night. She'd been to 2 podiatrists and couldn't get any relief. I don't know who the podiatrist was, I'm not interested. But she also was finding that taping would definitely help, but it wasn't getting rid of her blisters. Like, she could still get blisters in spite of the taping. And that basically mirrors my experience. So there's people out there that are getting blisters in spite of taping, and I want you to understand why. Because taping, yes, it stops things rubbing the skin, but it doesn't stop shear deformation. Sharon asks, would Vicks prevent blisters? It probably would, Sharon, to the extent that it is a coefficient of friction reduction strategy. It's like a lubricant, it's like Vaseline. There's no other mechanism here by which it could work. So you might as well just use Vaseline or Body Glide or something. Steve asks a great question, interested in medial plantar first met blistering. So the main thing I want you to know here is, although the blisters present on the medial side of the first MPJ and forefoot, the issue is on this medioplantar edge. So I call these edge blisters. It's a mistake to deal with like this part of the blister only. You've really got to deal with this edge as it goes from plantar to medial. So it's basically all the same things that we talked about with the forefoot valgus, plantar flex first ray, etc. But either there's a bit more pronation, so we're sort of loading more on the medial side, or there is a sport that they're partaking in that is very kind of side to side. So hockey, for example, I used to get these blisters. Hockey, we've got our feet apart a lot to push the ball and flick the ball, and so there's a lot of rolling onto that medial part of the first MPJ. And of course, the other scenario would be people that are wearing shoes that are too narrow there and they're bulging. So perhaps if they've got bunions, so the joint is bulging over the sole of the shoe and there's a real concentration of pressure there. I find the best way to deal with these is using Engo patches with the 2-patch technique. So that is, there's a patch on the plantar, on the horizontal surface and on the vertical surface of the shoe. So we've got a nice smooth join there, and therefore the sock can just slip and slide over that as it really needs to. The reason it's a good idea to use 2 patches is, number one, you'll be able to take the insole or orthotic out rather than leaving it in there, and or if you will need to take it out, you've just wrecked the patches. And the other reason is, if you're using a very cushioned insole, that will compress, every step that you take. And if that compression, it's also going to drag down the patch on the side of the shoe. So it's going to mean that it's just not going to last as long. So Engo patch, 2-patch technique is what we're after, plus all the other stuff that we've talked about in terms of bone movement and friction reduction. Nick asked a good question. Can you walk or run 100 kilometres blister-free? You absolutely can. How do you do it? Well, if you're trying to help a patient who's got this thing coming up and they want to be able to do it blister-free, here's how you approach it. You determine their blister history. So this is what they tell you about where they've had blisters before. I don't care what activity or how obtuse the factors were around when they got that blister. Just expect that blister to happen. There's obviously some sort of functional predisposition there, or structural predisposition. So expect that blister to happen. Also expect blisters anywhere where there is callus. So calluses are caused by the same forces as blisters, repetitive shear deformation. So it's a hint that if we increase our activity all of a sudden, then we're going to slip over from a chronic manifestation of repetitive shear deformation into an acute manifestation. So the chronic manifestation is the skin's just got time to lay down more skin. That's what a callus is. The acute manifestation is when it can't, and so we get that mechanical fatigue within the stratum spinosum of the epidermis, and that is the blister injury. On top of that, like if they don't have a blister history or they've not been so active and you just don't really have anything to go on, then have a good look at their structure and function, and you might be able to find something that is kind of likely. Perhaps they've got a Hageland's deformity, perhaps they've got a rigid plantar flex first ray or whatever. So I hope that the previous little discussion about the biomechanics and stuff has helped in that way. Once you've identified the most likely blisters that are going to happen, you need to find the best preventions for that site and then have them in place before you even start. It's a mistake on blisters that we expect, it's a mistake to just hope that they won't happen and say, oh, I can just nip it in the bud at the hotspot stage. Well, that often doesn't happen because either you don't feel the hotspot stage, depending on what you're doing, it can be relatively subtle and you just miss it, or you ignore it, like you're often sort of umming and ahhing about what you're going to do, or there's pressure to keep going, and by the time you think, okay, I'll do that, well, it's too late. You've got the mechanical fatigue and the blister is on its way. Even if it doesn't occur straight away, it can take 2 hours to form. And once you understand what the best preventions are, then you can nuance it for the activity. So, depending on the duration, do they have access to gear? Are there drop bags? Is there a support station? Are they carrying anything on them or not? Is it going to be a wet event? Like, is it going to rain? Are there river crossings? That kind of thing. That might help you decide on one prevention rather than another. But really, the best prevention for X anatomical location is the best prevention. And it really doesn't matter what the activity, except for this nuance. This is where you nuance it. Don't start with, I'm walking 100 kilometres, what's the best blister prevention for walking? Or I'm running 100 Ks, what's the best running blister prevention? That's not the way to go about it to get good results. You've got to start with the blister location, then nuance for the activity. Hope that helps, Nick. Matthew asks how to prevent them. Well, we've kind of gone through that with the chart and what we've just spoken about. So it's basically predict your likely blisters, choose the best prevention for that site, and nuance it for the activity. I think it's fair that we've done that one, Matthew. Let me know if not. Anshu asks, how do we manage them? So I'm taking that as, how do we treat blisters? The most meaningful blister treatment, that is treatment that's going to make the pain go away and have that blister maintain some sort of momentum in terms of healing, is to implement the prevention strategy that ideally you would have had in place already. So it's not enough just to put a cover on it. If you think that putting a Band-Aid or a hydrocolloid over a blister is all you need to do to treat it, then you are still in the camp of friction is rubbing. Yes, you've eliminated rubbing, but you haven't eliminated shear deformation. So even though you've got something over the blister, there is still shear deformation occurring within the soft tissue underneath that dressing that you need to address to take the pain out of the blister and help it heal quicker. This is a handout that I give to my patients that kind of just spells out what we do at each stage. So the idea is we start and we finish blister-free. To do this, we need to predict our likely blisters and have our preventions in place before we even start. If we don't do enough there, then we still have the hotspot stage. That's our last chance of blister prevention. In the hotspot stage, it's really important to stop straight away, and this is hard to do. Also, you need access to gear. So if you're running a marathon, you won't have any access to anything. So it just makes blister prevention before you even start even more of a good idea and more obvious. If you're hiking, then potentially you've got the time. But when we're hiking, there's pressure from the people that we're hiking with, even though it's probably more assumed rather than real. I just find that a lot of people miss it. Oops, sorry. If we don't do enough at the hotspot stage, then what's going to happen is we're going to get a blister, and he'll start with his roof intact. The good thing about this blister is it can't get infected. So the aim is to maintain that blister roof. The way we do that is we put a Band-Aid over it or some sort of island dressing, and we implement the prevention. So you'll see at each stage here, prevention is important. It plays a role throughout. So we implement the prevention because we want to get rid of the shear that's occurring in the soft tissue under the Band-Aid. So we need to have a plan, we need to have all the gear, or we just implement the prevention back here, we're not having to deal with it. If we don't do enough here, what happens is the roof tears, and now it's open to infection. So now we've got to add betadine or some sort of antiseptic into the equation, plus the dressing. Plus, we've got to implement prevention because we don't want this blister to get worse. We don't want it to get bigger. We don't want it to de-roof. We don't want it to hurt anymore. We want to give it some chance to start healing, even though we still have to be on it. So therefore, we have to implement the prevention as well as the antiseptic and dressing. If we don't do enough there, then what happens is the blister de-roofs. And when the blister de-roofs, we still need to implement infection control with the antiseptic and the dressing. So the dressing can either be an island dressing or a hydrocolloid. Hydrocolloids are great, but again, it's not enough. We've still got to implement the prevention. Just because you've got a hydrocolloid on there doesn't mean that that blister's not going to get any worse. If you have to carry on that activity, it's going to get worse. So, sorry to rabbit on. I hope that explains it. Caesar asks about sports injuries. I really don't understand what you're asking, Caesar, so perhaps get in touch and with some sort of elaboration, and I'll be happy to cover that next month. Excuse me. And finally, Jen asks a great question. How to target the best first therapy line for each patient, understanding that each blister is individual. So my understanding of what Jen is getting at is, there are different locations for blisters and they all have different sort of biomechanical aspects behind them. And each individual is obviously individual, so they have certain foot structure and function, they're wearing a specific shoe, they're performing a certain activity, there might be not much room to put a prevention in, blah, blah, blah. So how do we choose the first line therapy? Personally, I start at the top and I kind of, if anything, throw the kitchen sink at it. And then once I can demonstrate that that patient can be blister-free, then they can start peeling away different ones. And usually taping is the first one that we get rid of because it's usually not necessary. But if we just ignore my opinion, how can we know? Well, what did we learn at uni? Basically nothing. Nothing of any worth, I'm sorry to say, at least not when I went to uni, which was 30-something years ago. So that's not that helpful. If we just want to be going on research, then all of our preventions would involve a familiarity with the footwear and activity. So we're allowing for the adaptive changes in the epidermis. We'd wear densely padded acrylic socks, 100% acrylic socks. Now you can't get 100% acrylic socks, I've tried, but you could probably substitute that for moisture wicking, densely padded moisture wicking, or just go for densely padded, I think, but that's just my opinion. And Spenco insoles. We have an evidence base for Spenco insoles, but of course that's not enough. You can't use Spenco on hammer toe blisters or the back of heel blisters, and some people can be particularly familiar with their footwear and the activity and do all that they possibly can there and still get blisters. So relying on what research tells us solely is not enough either. You can try and get experience with blister management. This is what I've done since 2014. I've been going to 6-day ultra marathons and other endurance events, and that's how I've honed my skills in blister management. The Australian 6-day ultramarathon that occurs in Adelaide, which is towards the end of September, that is brilliant. That's really where I've honed it, because they're running on a 1.5k loop, and so they're running past my station every 1.5k, so 6 days straight. And they'll let you know if it's not working. And it's good because you get the feedback. Rather than you see a patient, you say, go and tape, do this taping technique, buy these socks, and they don't come back and so you just assume that everything's worked. Well, I don't want you to assume that, because like the telehealth patient, the Victorian netballer teenager that I saw last night on telehealth, she'd seen 2 podiatrists, neither of them was that helpful, and they've come away not knowing that there's more than taping and sweat management and the insoles that they were suggested to get, and they just happened to see something of mine online, so we did a telehealth. I'd rather not be seeing your patients. I'm quite happy to be seeing your patients, because that way they can get on top of their blister issues, which is my main aim. But even more, I'd rather podiatrists were finding blisters easier to deal with and more understood. So you were getting better outcomes. And therefore, you would see that patient and say, okay, even if you don't start at the top, start at the bottom if you like, but say, like, we'll try this now. If that doesn't work, I'll get you in again and we'll do this. And if that doesn't work, we've still got this to do as well. So, let them know that there's more that you've got up your sleeve, rather than, and listen, this was me 20, 30 years ago. I would see a blister patient, I'd tell them, I'd do taping, I'd show them how to do it. I'd say, if that doesn't work, get some lubricant. Of course, I'd check their shoes and everything would look fine. And then I would hope like hell I don't see them again, because I was out of ideas. So look, I've been in your boat basically, and I understand that what we are brought up with is heat moisture friction, but I want you to replace that with 3 different words: repetitive shear deformation, or just shear. Just don't tell your patients repetitive shear deformation, they won't understand. Just, excuse me, just tell them shear, describe what it is, do this on the top of their foot so that they can see and feel the difference between rubbing and shear, and that will help them see the light basically, and it'll help you understand blisters better. So by all means, get the experience by attending some sort of event. And when I say that, not just at the finish line putting band-aids on blisters, and not necessarily even sort of at aid stations where you do the best to patch them up with limited resources that are relatively cheap and basic, but really arm yourself with all the good stuff. Which I guess is what Jen is asking here. Because I suspect that what would be helpful is if we could rank blister preventions. Now, we can't really with any research basis, because most preventions haven't been researched to demonstrate this. I could rank them in my opinion, and I've been thinking about doing this for a while, but I've resisted because, you know, it's just my opinion. But I realise that I've probably got more experience than most, and I can see, like, from questions like this that it might be helpful. So I don't know, maybe in a future episode I'll cover this more thoroughly. So we could rank blister preventions for how effective they are, or how cost effective they are. So how effective they are based on their cost, so bang for buck basically. How long they last, are they easy to access? Just because it's easy to access doesn't mean it's a good thing to do or the best thing to do. Sure, you can maybe start there, but let them see that there's more. And of course, easy to apply, that can be something that is an advantage when people are out on their own doing their own thing. But in terms of quick wins, if I was just to give you something really quick that you could take away with you, my opinion about how effective blister preventions are, and I guess I'm saying this from a race medic sort of a position, so not in a podiatry practice, I'm talking more about sort of race support, blister support, foot care at races. I would go gel toe sleeves for preventing toe blisters, the majority of toe blisters, and Engo patches for everything else. Engo patches are great. Like, I mean, I know I sell them, but they are just so fantastic, and they are a product that if you don't want to have in your clinic, either selling to your patients or in your clinical drawer and using in a consultation, at least tell people about them, because they can just make so much difference. I don't think that there's any other friction reduction strategy that lasts as long and that takes up less room in the shoe and that is effective and durable. So they really are great, but I'm going to stop talking about that now. But anyway, that's my opinion on ranking blister preventions. Every blister I am presented with, I always have this in the back of my mind. I quickly discard that. I quickly have a think about that. Most people, they've done what they need to do or can do, and I'm focusing on all the things that we've talked about today. And I apply that to each anatomical location because it's really important to get anatomically specific. So that concludes our discussion today. I really do apologise for the audio issue and that we couldn't do this live because I'm really keen to get any comments and help understand and maybe learn something myself about the biomechanics behind it and all that kind of stuff. So we've had a look at the forces involved. You can see that we're dealing with a biphasic shear event with each step under the forefoot, and we've had a really good look at the opportunities to reduce shear deformation under the plantar forefoot, i.e. how to prevent blisters and also to implement that prevention during treatment. I want to thank you guys for your questions. I don't have a topic in mind just yet for next month. If you have something in mind, please let me know and I'll consider it. But apart from that, I shall see you on the first Wednesday of next month and we'll be talking blisters. Thank you. Bye for now.